Now the next speaker is Dr. Rajni. She will speak on ischemic heart disease in women current status. Last year she got the award for the best research paper. One of the most cited paper from the Heart India. Over to Dr. Rajni. Rajni.
टाइम कोशिश करेंगे. Good afternoon, everyone, all the dignitaries, chairperson, and all my seniors and colleagues here. So I thank you, Dr. Alok Singh and Dr. Rohit Tiwari, for always inviting me, and it is always a pleasure being this Baba Dham. I am very spiritual, as well as always I remember my old days of virtue here. So I thank you them for having me here. We'll start with today's topic for me, that is ischemic heart disease in women and what is the current scenario nowadays. So that everybody knows, as we used to think, till the woman attains menopause or crosses 50 years, we used to say, oh, your every chest pain is not a cardiac disease. So just take antacid and it will be off. So the scenario has changed in past 2 decades, and it has seen that now cardiovascular diseases are the leading cause of death all over the world for women globally. So overall, we have now more than 300 million cardiac disease patients as women globally. And we know that almost 10 million die of cardiac vascular disease when the data was taken in 2019. So there are a lot of issues and a lot of shortcomings why this is going up. So we know it is always women has been underrepresented in trials. So diagnosed, undertreated, and so many other issues which will be taken up in my coming slides. So as I said, this is the leading cause. Coronary heart disease in women is number 1, as almost 35% death occurs due to this cause. And globally next comes is the stroke. That is also similar pathophysiology which plays in this. Otherwise in India it is COPD. As we see the prevalence in India, women have 2.6% ischemic heart disease prevalence in comparison to men, which is 4.8%. And India, almost more than 19 crore Indian women are suffering at present with coronary artery disease. So this is the points which has been highlighted with the Joint Asia diabetic evaluation. They came to the points that the women who had ischemic heart disease were older than men, which was around in their 70s, whereas in men it was in their 60s. Women were less likely to receive the education, official education. They were less educated than men, so less aware also. So physically less active, and they were having the metabolic certain parameters which were making them different from their male counterpart. So I'll be highlighting it in that, including central obesity and certain other features. So atherosclerotic cardiovascular disease and heart failure as such prevalence wise, it was less in male, but it was causing more mortality in female. So more likely they have kidney disease and any site of cancer in the body. So if we talk of Indian women, the DMAT registry and another registry from Ahmedabad had shown that females are more likely to have the comorbid conditions, whether it is dyslipidemia and hypertension, diabetes, etc., which makes them more prone towards the atherosclerotic cardiovascular disease and the mortality associated with it. So I'm highlighting here the risk factors associated with it. The tradition we all know, increasing age, diabetes, smoking, obesity, physical inactivity, and so forth. But in the last 2 decades, there are certain emerging risk factors which has come up in women, which are making them more preponderant towards having atherosclerotic disease. What are these? These are the preterm deliveries, the precious deliveries, like more than 30-year deliveries now, because women are pursuing career, they are educated in getting educated in the late age also. So hypertensive disorders which they get in pregnancy, gestational diabetes, certain autoimmune disorders which are not properly diagnosed on time and making them to have higher incidence for coronary artery disease. Breast cancer, as I said, it is very prevalent all over the world, and those medications which are used for the treatment causing LV dysfunction and inflammatory state, which is causing direct cardiac toxicity and mortality in women. So, as we know, this whole world is becoming stressful day by day. So, depression and stress is the major risk factors, especially in younger population, to have increased sudden cardiac death. So the most common feature which make females separate from male is the metabolic syndrome pattern they have. So they have central obesity, they have more preponderance towards higher insulin resistance, more comorbidities like whether it is hypertension, diabetes, dyslipidemia, and the risk towards NASH, which all generate a chronic inflammatory state in the body, and more oxidative stress, atherogenicity, and then affecting all the organs in the form of whether it is stroke related or MI related. So these are the certain additional risk factors or risk enhancers which has been added by American Heart Association, and which has come up in these past 2 decades. In pregnancy, they have more coagulant state because they have now more metabolic syndrome nowadays. So more chances of gestational diabetes, more chances of preeclampsia, the polycystic ovarian syndrome, which is very common in female nowadays worldwide, and the early menopause, premature menopause, allaying the effect of the good hormone in female, that is estrogen. So that is going off early and exposing female early for ischemic heart disease. So this is the whole spectrum of the reproductive and then towards menopause effect of female, and what are the prepondering factors which make them for future ischemic heart disease. So if they attain early or late menarche because of hormonal imbalance, the major cause for that is the polycystic ovarian syndrome. Then if they have infertility in their reproductive period, which is also very common in urban cities, and a major factor has come up with them with the lifestyle changes and the stress. Then late reproductive period, they are achieving pregnancies in the later age, which is lot of stress, so hormonal disbalance, and they are not able to have the lactational period as it used to be before. So that is also making them having more ischemic heart disease in coming years. So menopausal, so they are achieving either surgical menopause like hysterectomy done earlier, or because of the UV and so forth, other oncogenic causes, and that also derange their hormones, and they allay the the positive effects of estrogen and progesterone hormone, and they lay up with ischemic heart disease. So what is the impact of this on women in terms of ischemic heart disease? Women with MI are more likely to have complications and increased mortality in comparison to male. So young females with MI, especially ST-elevated MI, have worse prognosis. So obesity prevalence is, when we consider metabolic syndrome in urban cities, the incidence is almost similar, but the females have more risk of CAD, that is almost 2/3 in comparison to 50% in men. So fewer women have very less representation in all the trials. So we are not have the definitive data towards what is the exact incidence, prevalence, and what are the factors, but we are still in, time. This changing time is telling us to educate more about the female body, so that we can prevent them having ischemic heart disease, which is rampantly increasing. So individuals with premature MI, especially women, they experience 2-fold higher mortality than men. So between 45 to 65 years, women are more likely to have heart failure within their upcoming 5 years of MI, which is not so in male. So as I said, the prime cause they could make out is their all hormonal disbalance, and the most common of it is clinical condition polycystic ovarian syndrome. So in that they have insulin resistance, dyslipidemia, obesity, coagulable state in the body, and other comorbid conditions also increases. So they have subclinical cardiovascular disease which get unnoticed, and then they present with frank MI in early 50s only. So the changes posed by PCOS is first they cause impaired glucose tolerance, which starts very early in the age, which get undetected. So 70% of the women with PCOS develops insulin resistance, and among PCOS women 53 to 80% are obese. So all these generate a chronic inflammatory stage which leads to venous thromboembolism, stroke, hyperglycemia, worsening dyslipidemia, and of course the increased chances of ischemic heart disease. So nowadays lot more trend towards like in vitro fertilization, because most of the women are pursuing or conceiving after 30 and 35 years. So it a lot of hormone induction to their body while that time, so more than twofold greater risk of having preeclampsia, which predisposes them for having early ischemic heart disease. So the most important, non-alcoholic fatty liver disease and NASH, which is also having lot of visceral adiposity, insulin resistance, and so forth, ischemic heart disease ultimately. So now with this explanation, at least I could have made you understand men is not equal to women in terms of ischemic heart disease. The general guidelines which come up doesn't separate out like this holds for men and this holds for women. So we have to work out on it, because the data also doesn't represent female population so strongly in all the randomized trials till now we have. So pathophysiology, lot of I have told. So they have more comorbidities, metabolic syndrome, more aggressively playing role in ischemic heart disease, and age-wise, and if we put classical risk factors, they fall into the low risk of developing ischemic heart disease. But when we use the risk enhancers and when we do the calcium coronary artery scoring, they fall into the increased high risk for ischemic heart disease. So all those factors we have to take into consideration. And with coronary angiography, it has been found they have less chances of obstructive coronary artery disease. They have symptoms but less chances of having significant obstruction in coronaries. So these are the, this I have explained already. The male counterpart would also be having hypertension, but the aggression towards developing ischemic heart disease is more in female than men. So smoking, similarly, low socioeconomic status, diabetes, as well as atrial fibrillation, all these have more rampant and florid chronic inflammatory state in female, which make them more susceptible to develop ischemic heart disease, and because of certain factors to have more mortality also. So as I said, so premature menopause, hormonal disbalance, so make them more dyslipidemic. In that they develop low HDL, and lipoprotein little a has a specific predilection in detecting ischemic heart disease in female. So generally it is not advised while a physician tests a women. So I tell them while doing fasting lipid profile, they should do also lipoprotein little a, which is more predictable in indicating ischemic heart disease in female. Similarly, triglycerides also hold a quite authentic role in detecting ischemic heart disease in a female patient. So this I have told the role of estrogen. So estrogen is protective, less LDL oxidation, so less platelet aggregation, increased nitric oxide. In all terms, it is good in vasomotor response. So when it decreases in female, it prepones them to have ischemic heart disease earlier. So symptom-wise, as we say, ischemic heart disease, most common symptom, chest pain, definitely for male, but not for female. So most common symptom in female is generally atypical, that is shortness of breath. So this has to be elaborated and given strength while detecting ischemic heart disease in female. And the next most common symptom is generalized fatigue. Sometimes they are not able to explain also what they are feeling. They will just say, I am not feeling good. I am not able to sleep in the night properly as I was doing like 1-2 years before. So all this has to be taken into consideration and evaluate all the ladies above 30 for ischemic heart disease. So 43% of female don't have chest pain at all. Similar way, all the same things I described here. So in diagnosis also, the simplest test we do is stress echo, or whether it is exercise, stress echo or dobutamine. But all these tests in general what we do is underrepresentative in terms of detecting ischemic heart disease in female. So we have to take certain, more reliable test, that is pharmacological SPECT or PET echo for such patients. So ACS with non-obstructive, I told females have more symptoms and less obstructive disease because of having the abnormal microvasculature response for vasodilation. So they have microvascular angina more commonly, and it has been properly detected in abnormal stress-induced cardiac MRI as well. And it has been correlated. Those who have abnormal cardiac MRI, they have adverse cardiovascular event in coming future. So I said instead of being like less traditional risk factor, it has been found having more CAC score, which helps us to start all preventive medications in such females to prevent ischemic heart disease in future. This is a chart which tells who have the high propensity towards obstructive disease should be tackled the similar way as guideline says. But if they fall into the low propensity to have ischemic heart disease or moderate according to the ASCVD risk, then we should look for the risk enhancer factors further to evaluate them properly. This is the management part. Obviously lifestyle changes, because the most common cause here is the metabolic syndrome and PCOS, certain pregnancy related factors, worse outcomes during pregnancy. So lifestyle makes a major chunk in treating such patient or preventing them to having ischemic heart disease. Then classical medications what we use is all similar as we consider for male counterpart. So in diet, as they say, to reduce weight or like for polycystic ovarian syndromes, definitely just having low carb diet or very low carb diet doesn't have a good health effect for preventing them having ischemic heart disease. So it is generally the plant-based protein which has been found to have good effect on ischemic heart disease pattern. So all these are similar as we see. For the only thing is that they have premature menopause nowadays, so thiazolinediones should not be given because they have found to have more fractures in this osteoporotic females. So this salt should be replaced with other anti-diabetic medications. All these are same as in men, like keep them calorie deficient to control weight. And in pregnancy, certain different salts we use for controlling hypertension like nifedipine, lepidotol and hydrolysine. Diabetes as in men, similar way. Dyslipidemia, same medication, statins, fibrate along with diet modification. Then insulin resistant, definitely in premenopausal we can use metformin, pioglitazone, and nowadays we are using SGLT2 and GLP-1 agonist as for PCOS patients to have cardioprotective role as well. Similar, SGLT2 proven role for non-diabetics to prevent them for future ischemic heart disease as well as having favorable PCOS pattern. Similarly, GLP-1 I told already. So the new concept is to have when female patient lands up, it is not physician, it is generally the gynecologist or obstetrician where they discuss their problems, and there this cardiometabolic clinic concept has to come up so that properly these females could be evaluated for their atypical symptoms so they don't land up with frank eye on one sudden day. These, I have already told, as they are underrepresented in trials, undertreated, underdiagnosed, so all the medications which should be given for the ACS patients, they are not given properly because it is not diagnosed on time. So ACE inhibitor, GLP-2/BH3 inhibitors, thrombolysis, whether it is PCI or CABG, all treatment modes are underdone for females. CABG, everything same, but they recover late and they have more morbidities, so more mortality in comparison to male while considering for CABG. Management for non-obstructed, the beta blocker has come up with a beta blocker has to be added and statins, which have shown proven role. So focus has to be taken, and this is some artificial intelligence has come up so that all the female can put up their all blood test on that side and their waist circumference, weight, etc. And the program can tell them you are towards high risk category to develop ischemic heart disease in future, and they can land up to some physician, clinician to rule out their ischemic heart disease in coming future. So take home message is CAD is the biggest health risk for women. Women are present differently and do worse when they get it. So most risk factors are same for men and women, but women are particularly high risk if they have diabetes, and gender specific risk like menopause and intake of birth control pills make them at higher risk. So women present late and referred less often for appropriate testing as well as management. Women can have more complications from treatment but still do better than without the treatment. Awareness is still less than it should be. Prevention can reduce risk, and screening program should be encouraged more in female. So thank you so much for having patience listening.
We are running short of time, so we will have question answer later. I request Dr. Alankar Tiwari to give memento to Dr. Rajni.
Now, here is a change in the program. Now,